Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order, so you can make use of it for the convenience of the study. So, as you know, we are all discussing about the topic approach to a child with developmental delay. So, today we will continue with the same topic. In the last class also we have seen a case, and now today we will have another important case. So let us discuss the case first. A 1 year 2 month old child, female child from Calcutta, second born to non-consanguineous couple with a marriage life of 6 years. Understand the case properly. Non-consanguineous marriage, second born. Now the child is 1 year 2 month, that means 12 month plus 2, that is 14-month old, and female child, and the couple has got total marriage life of 6 years. Now they come to the OPD with the delayed milestones of development as noticed by the mother, as the child is lagging behind or lagging back compared to the other kids. See, importance to know that mother herself noticed that her child is not doing properly as for the age in compared to other kids in the neighborhoods. Now, since there is a developmental delay, we should start from the antenatal period. So, whenever we get such cases where the developmental delay as complained by mother itself or as noticed by the physician itself, then always history should be begun from the antenatal period. Okay. So, in the antenatal period, we have to start whether it is a planned delivery or unplanned delivery. From there, you have to start. Then comes the whole intrauterine life, like intrauterine infections or any bad events, untoward incidents during the intrauterine life, IUGR, etc. So all these queries should be cleared. But as told by mother, in this particular case, there is no birth history evident. According to mother, the child was absolutely normal at the time of the birth. Child is cried immediately after birth, and there is no NICU admissions and all, and there is not even a history of HIE, etc. Okay. So we have to take the antenatal period, that is the intrauterine life history properly, maternal history, so that will do. Now, few more information about this case, that mother is now presently 24 years old. Okay. See, 24 years old, already they have completed 6 years of marriage life. That means she is married at the time of almost all 18 years. Okay. So, married at the age of 18 years. So, first child is alive, and the pre-pregnancy weight gain is only 6 kg. In the present child, that pre-pregnancy weight gain is only 6 kg. So, that was quite low. Usually, we expect about 10 kgs. So, weight gain is 6 kgs. And the height is 146 centimeter, and father is 26 years old. Father is also 26 years. Both the couples are very young now. Mother is 24 years old and father is 26 years old, and this is a second child. So this suggests that this is a teenage pregnancy. Therefore, the maternal weight gain is less during the pregnancy, and there is also adequate gap between the two pregnancies. So you can also notice that the gap is okay. The first child and second child, almost all 3 years of gap is there. Okay. So first trimester, now let us see the history. The first trimester, according to mother, the first trimester is almost all quite normal. There is no vomiting and there is no other illness. What happened in the second trimester? In second trimester also almost all it is normal, but mother feels that decreased appreciation of the fetal movement as compared to the first baby. So mother's feeling that she was not feeling that much of fetal movement as she felt during her first baby pregnancy. And all the scan was done, and in the scan there is an interpretation that there is collection of some fluid is there in the head. There is collection of some fluid is there in the head. So this was a history given. Continuing the history, and this is the only history which is given. Okay, so by considering this particular history, one thing is very clear: this is a teenage pregnancy. Okay, there is no much antenatal history or intrauterine history. There is no history of intrauterine infections or any antenatal bleeding and antepartum bleeding, etc. No such evidences are there. Teenage pregnancy, weight is less. Okay, first child is also normal, and the last moment mother felt that there is some less fetal body movements, and in the scan they are telling that some fluid is there in the head. Okay, only this much of history is evident, and there is no absolutely, child was absolutely normal at the time of the birth. There is no history of birth asphyxia. But still, mother complains that my baby is not acquiring the developmental milestones as compared to the neighbor would. Okay. Now, this is, my child is having some developmental problem, mostly developmental delay. This is the mother's version, not the doctor's version. Mother feel like that. Okay. So maybe he is lagging back. So therefore she visited the doctor, pediatrician, and now the question is what you will do next in such conditions. Now here we have to go for 3 important plans. As I explained in the earlier classes, whenever such cases comes, one is developmental surveillance, developmental assessment, and one more plan. Okay, developmental screening. So that has to be done. So which one of these 3 has to be taken? So that is very important. If you know, I can show you, we have shown these 3 important plans, isn't it? So whenever there is, one is developmental surveillance, developmental screening, and developmental assessment. Developmental surveillance is a continuous one. Developmental screening is, in a particular day we call all the babies irrespective of normal and abnormal babies, and then we'll screen. And developmental assessment is, once you pick up that baby is having developmental problem, then what to do. Okay, so in this case, so therefore in this particular case where the mother is complaining that my child might have been having developmental problem, so you have to go for developmental surveillance. Okay, so we have to go for developmental surveillance plan. Okay, so here we have to adopt a simple developmental surveillance plan. Take use of the well child disease to monitor the development and link it with the vaccination visit. So in this child, what you have to actually tell, or not only this case has been taken as example, even to the other kids also. Usually for simple developmental surveillance plan, we have to make use of the vaccination visits. Many times patient comes to you with the kids, mother comes to you with the kids for the vaccination. Most of the time what we'll do is simply we administer the vaccination and send them back. But we have to make use of these vaccination uses to go for the developmental assessment of the child. See, child is coming at the age of 1.5 month, 2.5 month, 3.5 month, at 6 month, at 9 month. Okay, many times child is coming in between. Every time if you are able to do the developmental assessment, then, or that's called a simple developmental surveillance plan, then so many such developmental problems may be easily and earlier it can be picked up at the earliest. Earliest you diagnose, better will be the prognosis. Okay, so minimum 6 visits of vaccination will be there, isn't it? 6th, 10th and 16th weeks, then later onwards for hepatitis A, hepatitis, then hepatitis B, etc. and all. So another option is, this is one option. Okay, another option is you can give a milestone checklist to the mother. Give the checklist of a milestone so that mother go on ticking, putting the tick on that, and if she finds that something is lagging behind, immediately she can consult the doctor. Okay, these are the 2 very important options that comes under for this case and also for all the other babies, that either you take a full opportunity of the full advantage of the vaccination units to examine the baby so that any developmental delay cannot be missed and it would be identified at the earliest. Number 2, give a milestone checklist to the mother so that she can understand. So some common early childhood developmental problems that we have to see is, okay, so by taking this case as a base, we will discuss all these things. Some of the common early childhood developmental problems that we will see is, number 1 is language delay. Okay, language delay. So that is one of the earliest problem. Now, autism spectrum disorders maybe, or sometime global developmental delays, then hearing loss, isolated hearing losses, vision impairment. So these are all some of the most common developmental problems that we can pick up as far as language delay is concerned. So language, usually by 7 month or 8 month baby start telling ma, pa, then bisyllables by 9-10 month amma, appa. So So that will be there, but you can pick up this delay at the earliest, because babbling will be start even after by 4 or 5 months itself. The babbling will clearly start. Okay, so if the language delay is there, most of the time language delay may be because of the hearing problems, okay, or communication problems, hearing problem or vision problems. Now hearing loss, see, hearing loss is, that is deafness. Deafness is one of the most common complication of almost all the, what you say, intrauterine infections, torch infections, especially with the cytomegalovirus. Okay, so therefore the history, antenatal history of intrauterine infection is very important. Similarly, vision. If the child has got hypoglycemia at the time of the birth, okay, mild hypoglycemia or what, moderate hypoglycemia at the time of the birth, maybe due to birth asphyxia or some other reasons. Most commonly, the occipital area and of the cerebral cortex will be affected, and the retina, that will be affected, and vision problems are very common. Even in some of the congenital cataract, etc., we will have the vision problem. Okay, so that's one part. Number 2 is autism. Otherwise, the child may have clear-cut autism where social and as well as language developmental delay will be very, very clear. So anyway, once you pick up the language delay at the earliest, so that will be a very good guideline. Now in Vedana Adhyaya of Kashyap Samhita, if you see, he has mentioned so many things to identify the autism at the earliest. That we will discuss in the next class. And traditional Indian method of singing the, what you say in Kannada, we say Jogula or Rori in Hindi. So to make a song which is sung by the mother to make the baby sleep. Okay, so that is also one of the best way of identification of earliest hearing problems. If the child is able to enjoy your song, definitely child will go into sleep. And if the child is not enjoying your song, how beautifully you song, that is a different issue. But if the child is not, it may not respond for your song. So a clever mother can even identify the deafness at the earliest, or language problem or hearing problem at the earliest. Anyway, so that is one issue. Language delay should be picked up at this particular age. Similarly, motor delay. Talking about the motor delay. Suppose if there is brain injury at the time of the birth, if the child is preterm. Now in this case actually she is a, teenage pregnancy. Okay, there is even chance of preterm deliveries will be there, but the history is not suggested in this case. So otherwise the brain injuries, preterm babies, IUGR babies, then ischemic encephalopathy, or otherwise neonatal jaundice, hypoglycemia, global developmental delay, chronic disorders. Okay. For example, congenital pyloric disorders, congenital megacolons, some of the congenital cardiac disorders, neuromuscular problems, and nutritional deficiencies, rickets, inborn errors of metabolism, etc. Then vitamin B12 deficiency. See, these are all actually cause for the motor delay. Okay, gross motor delay. Now, vitamin B12, that is very important for the myelination of the nerves. Okay, so there is some Friedreich's ataxia-like conditions where vitamin B12 is problematic. Okay, absorption of the vitamin B12 is hereditarily get affected, so that may lead to this problem. Nutritional deficiency is very important, so that is one of the most common cause for the motor delay, especially motor delay. Nutrition problem we don't have in the language delay and social delay. Nutrition problem you will have the the motor delay, gross motor delay. Similarly, chronic disorders. Okay, chronic hemolytic disorders, chronic cardiac disorders, chronic renal disorders, megacolon, pyloric stenosis. So these are all the causes for motor delay, which has to be identified at the earliest. So regular examination of the baby during the time of the vaccine visits, so we'll go to help it. Otherwise, you have to provide a checklist to the mother so that she can identify by herself and then report to the physician. So usually in the 9-month visit, if you are talking, so vision and hearing should be seen and motor impairment should be in 18-month visit. Okay, maybe for the DPT booster and all, 18-month visit. So subtle motor impairments, then language and social communication impairments should be clearly understood. 24 to 36 months, again, language and social communication impairments and intellectual impairments should be understood. Talking about birth to 8 month, so starting from birth to 8 month in the well child visit, when the child is coming to you during the vaccination and all, so how you will go through. Okay, so these are the things that you have to follow. You have to watch the hand preference, then you have to do the growth monitoring, head circumference, vision and hearing responses. So these are the things that you should not miss every time when baby visit you for the well child visits. What are the red flags? Some of the red flags is if there is no head control by 5 months. By 5 months also, if the child is not having head control is maximally attained by 3 months. But if it is not by 5 months also, definitely it's a red flag. There is no interest shown towards the toys and not keenly looking at the faces. That is also a red flag. By 5 months, I'm telling. Not turning and localizing the sounds. Okay. So any sound is a child usually looks at the sound. A preferential hand used to reach for the toys, either right hand or left hand. Preferential hand use will be there. So if the baby is not having this by the end of 5 months, again it's a red flag. Similarly, microcephaly and failure to thrive, it's always a red flag. So this is about the case 2, where the mother has been coming to you with the doubt that my child has got developmental delay. In such condition, which surveillance plan you have to use and how you have to proceed, and what are the red flags and what are the important things that you have to pick up, that we have discussed through this case. Thank you very much. In the next class, we will discuss one more important case. Thank you.